So my name is Dr. Lesage, and I am from BI here and attending in the palliative care department. So today we are going to talk about symptoms and some of the symptoms that are other than pain. So far in the year we concentrated a lot on pain. There's still one session on pain, and that was supposed to be given today, but that will be given next week. Half of it will be on rehabilitation medicine and how we can deal with pain, all those devices that we can use to decrease the pain, and also some psychological modalities in order to decrease pain. But that will be next week. So this week we are going to talk about nausea, vomiting, and constipation. So first let's start with some symptom burden in serious illness. Of course, pain is always the one prevalent, the one that we target first and the one that we talk the most about. But there are also some other symptoms that are quite, I would say, quite detrimental to the patient, quite annoying to the patient, and for which sometimes we need to work a lot in order to alleviate those symptoms. So symptoms varies with the type of illness and the cancer. We all know that we won't have the same type of symptoms in maybe cardiac versus cancer. It will also vary according to the advance of the disease. Therefore, at the beginning of the disease, you may have some symptoms, and you may have some more at the end of the disease. Like pain may intensify, nausea, vomiting may be a little bit more common at the end, and so on and so forth. So they varied according to the disease and also according to the stage of the disease. So just to give you an idea, of course, this is changing probably. This was published at the end of the 90s, and you can see that other symptoms are also, these are other than the pain, although you can see that the pain is 17, and then you might find that very surprising. And this is an overall, because pain usually will be much more than that at the end of the disease. The more you progress in the disease, the more pain it is expected to have. But you see that dyspnea is fairly common. Almost 20% of the patient will have dyspnea. Pain and dyspnea, combination of that, anxiety and depression, 4% of those. A combination of symptoms, as you can see, it's not uncommon that you have multiple symptoms, and nausea is about 3.7. Don't take that for granted. This is an overall, but you will see that in certain diseases like GI, it's much higher than that. We'll come back to that in a second. Again, it varies with the disease. In the HIV/AIDS population example, in the early HIV, you will see mainly asthenia, anorexia, pain. Late HIV, you will see more than one symptom in 75% of the cases, and more than 50% will have pain. In the terminally ill AIDS patient, then again, anorexia will be the number one of the symptoms. Fatigue, a lot of fatigue, and pain also will be quite predominant. At the time of death in HIV population, you can see that fatigue is very important as well as dyspnea. So in the cancer population, again, this is probably in an overall, does not take into consideration the staging of the disease, but you will see that in the overall population of cancer patients, 50%, more than 50% will have pain. Anorexia 30%, nausea 20% of those, so 1 out of 5, and confusion and dyspnea in 20%, as we said before. In advanced heart disease, again, we will see a combination of other symptoms, which makes sense. Pain can be there. Dyspnea, we know that will be really oftentimes reported. Low mood, we're reporting about 50% on the last year of life. Another array of a lot of symptoms that you are going to find as well: anxiety, constipation, vomiting, so on and so forth. So most symptoms were distressing. This is one thing to have symptoms, and this is another thing to be distressed by the symptoms. Memorial developed many years ago a scale that was targeting the number of symptoms that you were having, but not only that, but the distress that those symptoms can bring. You may have pain, but you may not be distressed by that pain. You may be able to cope. You may be able to go on with your activities. The same with dyspnea. You may be very, very short of breath, but you get used to it and it's not too distressing to you. So the important thing, and this is one thing that we rarely measure because we rarely ask the patient, are you distressed by it? Sometimes we do that when they will report that they have hallucination, example. And we'll say, well, you know, is that bad? Is that good? Does it distress you? You see things on the wall. Well, if they are beautiful things, we don't care. They are angels on the wall. Maybe it's not so distressing than if it is bugs or something like that. So again, the level of distress can be quite different than the symptom. Now, let's concentrate on the two first part of the gastrointestinal symptoms. The other part, the cachexia as well as the bowel obstruction, will be addressed in another talk. So, in this nausea and vomiting symptom, we are going to talk about prevalence, etiology, pathophysiology, assessment, and management. So prevalence, again, the prevalence of any of the symptoms will be depending on the disease that you are talking about. If we saw some general information, well, they are not applying the same thing for various types of cancer or other diseases, chronic illnesses. So nausea is fairly common, as you can see, almost more than 50% in advanced cancer. So it's something that we need to be able to deal with because it's really something that is fairly common. It will be more common in women. I don't know about that. I never realized that, but because maybe women had more breast cancer and cancer that are conducive to have that kind of symptom, probably. In breast, stomach, and gynecology cancer, it is usually more frequent, and in patients receiving opioid. As we know, as a side effects of the opioid, one of the side effects is the nausea/vomiting, although this is something that should be treatable fairly easily. 3 to 7% of patients hospitalized with serious illnesses and highly prevalent in AIDS patients, about 7% in serious illnesses. So in cardiac patients, COPD, this is not a symptom that you do see all the time or oftentimes, not as much certainly as cancer population or HIV/AIDS. Like everything, if somebody was asking you, what's the cause of the nausea? Because again, if somebody is calling you and say, what kind of antiemetic would you like to give to the patient? Well, the answer is, I don't know. Because you need to know a little bit more about what you are dealing with. It's a little bit like pain. What kind of nausea do you have? What it is, what are the factors causing it, and so on and so forth. So you need a little bit, some inquiry before you get to the treatment of the nausea. And like everything, it's easy to divide that in two things, related to the disease or not related to the disease. So it's already a broad division in your head and then can help you to sort out what's the cause of the disease. So related to the disease, it can be something that has to do with the GI structure per se. It can be something like has to do with hypomotility, obstruction, constipation, CNS disease. And it can be related to the treatment. And it's something that we forget. Chemotherapy, radiation therapy, surgery, drug-induced. Opioids is one of those only, but there's maybe many other drugs that can be also related to treatment. So sort this out. Is that really a functional type of thing, or it is really related to the treatment? Or it can be not related at all. It can be simply, and we know that in especially in our cancer population, that they have a lot of other disorders, mainly metabolic disturbances, renal, hepatic failure, insufficiency, hypercalcemia, hyponatremia, uremia, name it, all those causes also. And of course the treatment will be very different if you identify that this is the cause versus just throwing an antiemetic on the patient. And keep in mind that the fourth category, which is often there in almost all our symptoms, is the psychological factors. Anxiety, that or depression or affect or disorders or things like that that can modulate your symptoms. It is true for pain, it is true for any other thing as well. If you are more anxious, there is such a thing in an entity that's called prior receiving chemotherapy. Patients start to be already having nausea even before the treatment is given. We call that anticipatory nausea, which it's related usually to anxiety, and for which the treatment will be probably something like a benzo, something very different than another antiemetic that will be useful for other cause of nausea.
Often cognitive behavioral interventions also, but I think that they're working really hard to prevent that now.
Yes.
The anticipatory nausea and
Yes.
vomiting because the medicines are so available and such like that, but oftentimes it's...
And also because it's better recognized also, perhaps, and then you can identify the patient who will have that, and then you can work with all kind of, and we come back on that, that may decrease that nausea, which can be very annoying to the patient, up to the point of sometimes for patients they may withdraw from chemotherapy because it's too much, they cannot master those symptoms.